I was definitely getting frustrated, but I didn't let that show. But do they understand the severity? And I remember letting them know, hey, there's a chance she could be bleeding into her pelvis and she could die. And this time's important, we could save that time and get her to the ER and they can fix it because it's not going to get fixed here. And as long as they knew the gravity of the situation and it's like, okay, the absolute worst outcome, I let you know and you still don't want her to go with us, hey, that's when we decided, like, yeah, there is nothing we can do.
Soundstripe.
Welcome to In-Service, the EMS Podcast, where frontline experience meets leadership insight. Hosted by Jason Falvey, a seasoned paramedic and EMS leader with over 30 years in the field. This show brings you conversations with people shaping emergency medical services today. From street-level medics to innovators on the bleeding edge of EMS, we dive into real stories, leadership strategies, and what it takes to build high-performing teams in high-stakes environments. Let's get in service.
We copy you down, Eagle.
Matthew, an experienced paramedic with a decade of field experience. He is renowned for his clinical expertise, rapid assessment skills, and effective scene management. Matt is dedicated to delivering high-quality, compassionate care in challenging situations and is committed to professional growth and mentoring the next generation of EMS providers. Christian is embarking on his paramedic journey while bringing a fresh perspective and enthusiasm to the role. Christian also builds on his expertise in emergency medical services. Christian is focused on clinical excellence, patient safety, and continuous professional development. As former partners, Matt and Christian share unique insights into teamwork, high-pressure decision-making, and professional growth that comes from years in EMS. Their experiences are filled with practical strategies for clinical excellence and scene management. All right, welcome, Matt and Christian.
Hello.
Hello.
Hey, thank you for coming in tonight. It's been a long day, so we're here a little bit later doing this. I appreciate that.
Of course. Very excited to be here.
Indeed.
Yeah, I'm pretty excited to sit down with both of you, and we're going to talk a little bit tonight about partnerships, what makes them work, what are the red flags in a partnership where maybe this isn't going to work, and how do we handle that? And Matt, you've been in this 10 years, nine years as a paramedic, and Christian about 5, but you're a new paramedic.
Yes, I am.
So now you're the lead paramedic on your own ambulance?
I am.
With your partner?
It's been very exciting. I was on Matthew's truck for actually about 4 years. I enjoyed working with him so much that it was almost a difficult decision to decide to go to medic school, but I'm glad I didn't. It was a long, almost 2 full years, but I've had my own full-time partner now for about 4 months, and it's been excellent. There's definitely moments where you realize that you are now a paramedic. I didn't think leadership responsibility would be so apparent, but it is, and it's been exciting to learn, and we're just going through it. It's been pretty excellent so far.
Yeah. I worked with Christian, for 4 years and then a little bit, because when you were part-time in medic school, we picked up a good bit together. And now I'm actually full-time with Christian's girlfriend. And gosh, it's been great. She's a great EMT. And I still get to communicate with Christian. So that's awesome.
And Christian's partner was actually partners with your partner prior to Christian going out on his own. So that's pretty cool, too.
It's been excellent. They were a BLS unit, so it was 2 very capable advanced EMTs on a BLS unit. So when they split to get paramedic partners, it's almost essentially working with another lead position. They were so used to being in command and control on their own. So I'm incredibly grateful. Her name is Shelby. I can trust her with any decision, and I'm very grateful that more so she's trusting me with hers. I thought that it's been really cool that she's been able to really let me grow as a brand new medic and make most decisions. She went from being an excellent decision maker and a very capable on-scene management role to being just a really good support for me. So I couldn't be happier with who I'm working with.
Yeah. And your partner, Matt, is Michelle?
Yeah. Michelle, she's, yes, much of what Christian said, like her leadership skills show. Most EMTs have a medic partner, so the burden of the big decision-making falls on the paramedic. So both of them having those decision-making skills, it's been great with Michelle. I've been a medic for 9 years, so where Christian and I are at as far as, I guess, our career paths, yeah, he's learning how to do those leadership skills. And I mean, you're always learning. I'm learning still too, but I don't have to. Me and Michelle take turns as far as our leadership goes. Like, she still is very capable and able to make judgment calls, and that I agree with as well. And it's been refreshing for the past couple of years. I've just been floating through different EMTs. I haven't had a full-time partner since Christian, so. And most EMTs don't have that burden of making those big decisions on scene. So having Michelle as my full-time partner, it's been great. She's really good at that and just a fun person to be around. So.
Yeah, Michelle and Shelby are excellent EMTs. I'm very fortunate to be able to work with both of you and both of them as well. They're very good.
Powerful group of people.
That is correct. Yes. Christian, where'd you grow up? Where are you from?
I grew up here. I'm a born and raised Georgia boy. My whole family's from New Orleans, Louisiana, so we've got some Cajun bloodline, but I was born and raised in Cherokee County, which is rural, urban Georgia, a lot of neighborhoods. I went to school in Georgia Southern, which is in Statesboro. It's more of a rural, nothing else around the college town, and I've just been rooted in Georgia my whole life.
How about you, Matt? You're from?
I am from Plano, Texas, but I moved to Woodstock, Georgia in second grade, and yeah, been here ever since. I went to Chattahoochee Tech. Are we allowed to talk about our school names, right?
Sure. Yeah, absolutely.
Okay.
Where'd you go to school?
I went to, that's right. It's
What an
confidential.
awful thing to say on the microphone.
I can't help it.
Incredibly rude.
That's what I do when I get nervous.
No,
I
you can
swear,
certainly
sorry.
say it. Chattahoochee Tech, yeah.
Yes.
Great.
I went
Good school.
there, got my associates in paramedicine, and yeah, that's where I grew up.
So what inspired you to get into EMS in the first place?
For me, I have a lot of nurses in the family, my mom, my sisters, my aunts. So I knew I wanted, and my dad was a chef, so that's what I did before this. I was a sous chef for 6 years, and it wasn't really cutting it for me. Wanted something a little more fulfilling. Getting paid to help people sounded nice, so.
It's way cooler, by the way.
Yeah, something a little more interesting and fulfilling. And I was thinking nursing, and just throughout my schooling realized that paramedicine would be the best fit for me. And it's definitely the right call. Yeah, I guess getting paid to help people in their most time of need, it's sounded great to me, and it still does. It's a nice.
What about you, Christian? What got you into this?
As a little kid, I thought the ambulance was so cool. This big truck, all these flashing lights, and that everyone moved out of the way. As you get older, though, you realize that there's more to that, and that's even kind of the dangerous part. But as Matthew said, to be able to be the first person to be there for someone that needs it is pretty rewarding. I've always felt that I was good with people, and that I would hope that even if I can't be the most clinically sharp or decision maker, that I could be the person this person is grateful to see arrive. It's a powerful feeling. It's very gratitude receiving.
Yeah, I agree.
Gratitude receiving. That was dumb.
Any particular?
I cut that. That didn't make sense.
No, I won't cut it out.
Thank you.
Any particular EMS calls stand out for you?
All of them.
How about a call you were both on together?
Ooh, we've had some
debate
We've had
this.
some excellent ones. I think the one that I always think of the most is a car accident that we discovered before it was even dispatched.
Yeah.
We did the entire scene management from start to finish. For those that don't know, we work for a private company that responds with county fire departments. And so in most cases, those fire departments beat us there. Fire trucks are parked around. They've controlled the scene by the time we get there. In this particular incident, we just happened to be driving through an intersection where moments before, a large pickup truck full of teenagers had ran a red light and really struck a Camry with about 2 or 3 other occupants. And many of them were hurt. I would say only 2 or 3 required intense medical care, but it was just 4 or 5 kids running around screaming, cars smoking.
It was tricky because they were all under 18 as well, and all their parents were hours away, and if they're under 18, they can't make their own medical decisions, so we had to contact all their parents while we're trying to assess how severe this head wound is, and I'll let you talk about that.
Yeah, I think looking back, there was of the 6, we had a girl with a closed fracture. We had probably a couple concussions, but the most alarming and eye-catching was this poor 16-year-old girl came up, and her whole face is just covered in blood. And she's alert, she's oriented, she's able to walk around, but she was in the back seat, and she hit her head on the big bulk of the handle of the truck and had an avulsion from right down the middle of her forehead that went all the way to her ear. So not to be graphic, but you could pick up her eyebrow and fold it over like a page of a book all the way to the back of her head.
Yeah.
And she was asking if we could see her brain. And so she was aware that she was hurt badly. She was aware that it was bleeding. It wasn't immediately a lay down trauma naked, but that was one of the first people to approach us. Like, oh my goodness, if this is the first person we're seeing, what's left in this truck? And luckily, she was the most critical of, if any of them are critical. I think we had 3 people in our ambulance, a second unit come and get 2. We had a supervisor come, and he was very helpful. But that was just alarming from the start to finish because we didn't even have time to prep. Here's an accident. Let's see if they're hurt. Oh my gosh, you can see your skull.
Yeah, we remember we walked out and you approached the female that was most critically injured. And the first thing she said was, "Am I gonna die?" And what did you say to her?
You nailed her accent. I'm like, no, just sit down for a minute. I'll be right back.
Yeah. Yeah, we both stayed pretty calm, which was important. And that is what you call a distracting injury for sure. That looks awful. But, hey, we can see your skull, and it's not cracked. It's nice and smooth, the little bit we see.
Healthy white color.
Yes. You're walking around. You're alert. You're oriented. One of our first priorities was covering up that head wound so we don't freak out all the other 16-year-olds that are, if you see that, you're going to start freaking out thinking maybe I'm injured more than I am, and that'll create a whole mess. So we wrapped that up pretty quick, and then, making all those decisions, like where do they go, which hospital. We're 5 minutes away from
a trauma center.
Yeah, the trauma center, but we're 20 minutes away from the hospital for children. Are they children? So we definitely made the right calls. That one was tricky.
That was a good one.
Being there from start to finish was nice. We don't get to do that often. There's a lot of tough calls we had to make. And that was a good one.
And at some point, 9 years in, you pretty much know what's going on when you walk through the door. You've seen so many respiratory distress calls at this point that you can tell when you walk through the door how bad this really is, just from a doorway view.
The main thing that I've done differently in my approach as far as my assessment goes from when I first started till now is not being so literal. We maybe think this person's having a stroke, they got some weakness, and I get on scene and I say, "Hey, how you doing?" And the patient is walking up to me and it answers me, and his speech isn't slurred. It's in my head. I've already done my stroke assessment. I can further detail that if I need to, but he's walking, his face is symmetrical, his speech is not slurred. So I've pretty much done my stroke assessment and ruled that out within the first minute. And whereas when I first started, I'm like, okay, this person might be having a stroke. I need to talk to him and perform a stroke assessment and do all the things. And so I guess being privy to those little things, like being able to assess your patient when you're not asking them a direct question and you're observing them and knowing that, okay, A, B, and C's are intact, and not having to actually do every single thing separately. It's not all
you're
separate.
Drawing it
it's
all
together.
in. Yeah. What's interesting, you show up to a patient who's maybe... You show up to a patient's home and they're experiencing dizziness. As I'm approaching them, probably the first thing I'm doing is touching their wrist and checking a radial pulse.
Absolutely.
Because I'm gathering their skin temperature, whether it's dry or wet, their pulse rate. Is it fast? Is it slow? Is it weak? There's a lot you can gather just from that approach alone as to what's going on with this person.
A major adjustment that I was almost embarrassed to discover I needed to make was I had to switch from EMT to paramedic. And everyone remembers the assessment chain. And so I'd walk in on scene as one of my first paramedic calls, and I'd feel for a pulse, and I would find it's there. And I found a pulse. But I found that I wasn't actually interpreting it. I would just going through the motions of A, B, C. I've done it. I've checked off in my head. We'd have the patient on the monitor, and the pulse rate was 40. And I'd be embarrassed. Like, I felt the pulse. But in my head, all I had to do was just confirm in my head that they had it. I'd need to do more of that now. I need to focus on interpreting. Was it bounding? Is it weak? Just because it's there doesn't mean it's you're done.
Yeah.
So that's been an interesting, and I'll do a blood pressure, and I'll see he's 90/60. Now I have to, okay, what does that mean? Is it perfusing? Is this normal? Is this a reaction to what's happening? Is this unrelated? Rather than just simply obtaining it and repeating it to a paramedic.
Yeah, switching from that EMT role to more of a leadership role. Yeah, that is an adjustment. That's something I didn't deal with a whole lot because I was barely an EMT, but I can see how that would be challenging.
I'm not just collecting data anymore. I'm analyzing it, and that felt all of a sudden it was a revelation. Oh, yeah, this is not a good pulse. We need pads on.
Yes, this is irregular and slow and weak.
That's certainly how it's changed a little bit, and I'm getting better at that. I think I'm far more adaptive.
Outside of the accident that you guys on-sited, have there been any other calls that you found especially challenging from a scene management perspective? And what did you learn from that?
The one that immediately jumps to my mind, we were talking about a different one, is we had a car accident with a Middle Eastern family, and it was of a culture that their women can't speak or be touched by a male. And it was 3 men and 1 woman, and she was the only one that needed a true assessment. She was in the most damaged part of the car, and that was certainly tricky to navigate. We weren't allowed to speak directly to her. We weren't allowed to touch her, and she's been in a traumatic injury. So I think we were concerned about a broken hip. She couldn't stand.
I remember this.
Yeah, and the first thing we tried doing was asking the limits or what rules are we allowed to kind of get bendy with here. And it was very rigid. They weren't going to really buckle on anything. So we're like, okay, well then you need to, if you're the husband or the brother, can you palpate and feel around? We're trying our best to explain how to check for the stability of a hip, and they just couldn't really, even if they were doing it correctly, we weren't getting the information we needed. They refused to expose her, which she was fully garbed. So we had no idea if she's bleeding anywhere. We don't know if any bruises or any signs of something. And they were very adamant. We couldn't even have them put her on the stretcher for us. We tried seeing if they would do everything. That was pretty tricky.
Yeah, they weren't comfortable with that. They weren't comfortable with us assessing the patient at all. No hands on the patient, and a pelvic fracture.
You couldn't even speak to the patient, right? Is that it?
Correct. She wasn't even allowed to turn towards us. So I couldn't even get creative with hand gestures or simple yes or no's. It was a very rigid, there's zero communication. It's not even just verbal.
Yeah.
And I can't nod yes or no. You can't speak directly or indirectly to me.
We tried for a minute to adapt to that situation and, use them as our hands. And we found out pretty quickly that we are not going to be able to gather enough information, but this patient needs to go to the hospital. So we ended up having to get another unit out there that was, luckily there was another unit in service that was 2 females, and we were able to get them to come to the scene, and they handled the situation. And I don't know what the outcome of that was, actually.
I think they did say it was a fractured hip.
Yeah.
I don't remember hearing how critical. The concern was that she couldn't move at all. She couldn't even turn to get out of the vehicle. The family was trying to usher her to stand up, and she was just frozen in pain. And I fully garbed all the way to she had I hope to not call. I believe it's a burqa. So we couldn't even see skin tone. We couldn't even see if she was sweating. We couldn't. There was zero assessment there. It was very difficult.
We were also in the middle of an intersection, and we're having to wait for this other ambulance. We were busy too, so
it took a minute.
It took them a minute, and then I think by the time they got on scene, the tow truck was there. It's like this. They're trying to get this car out of the middle of the intersection. Traffic's crazy, and she's still sitting in the back seat of this sedan, and she could be bleeding out into her pelvis. There's nothing we can do.
Even if you could assess her or even speak to her, they weren't going to let you transport her anyway.
No.
There was no way you were going to be in the back of it.
No, and we were even asking further questions. Well, if we get to the ER, it's more than likely going to be a male ER doctor. So what can we do for here? And I remember I thought we did a good job we were very patient. I even think we were pretty understanding and cooperative to the best of our ability.
Oh, yeah.
No one else on scene was. We had some very upset firefighters, and we had some very pushy and pretty aggressive truck drivers that were very comfortable talking about the differences that we have. And at this point, it was a bit of a frustrating difference, but that's not our place. In the same way that if she was a different culture that could speak to me and didn't want me to touch her, didn't want to go, didn't want an evaluation transport, I had to respect that as well.
Yeah.
This was just one where I didn't know how. It was almost, is this under operations of if it's a child, if they're not a decision maker in their culture and their family? It was very difficult. It was very strange.
Yeah, like are we supposed to use implied consent? Just negate what this person's saying? Because technically she's alert and oriented and she can make her own choices.
Maybe.
Maybe she can't because she won't talk to us because she's not allowed. And I was definitely getting frustrated, but I didn't let that show. But it's like, do they understand the severity? Like, and I remember letting them know, like, hey, there's a chance she could be bleeding out into her pelvis and she could die. And this time's important. We could save that time and get her to the ER and they can fix it because it's not going to get fixed here. And as long as they knew the gravity of the situation, and it's like, okay, the absolute worst outcome, I let you know and you still don't want her to go with us, hey, that's when we decided, like, yeah, there is nothing we can do. We just have to get another unit here. And luckily we were able to. It was very tricky.
Right. Because you don't even know if she's an adult.
Yeah.
And
or if she's even supposed to be with these people, if she's related to them at all.
Yeah. Very challenging situation. Fortunately, you guys turned to a very good leader who was able to provide you with some direction.
That's right.
Yeah.
Shannon, the female firefighter that showed up on scene. Thank you, Shannon. Shout out, Shannon. And of course, our supervisor.
Listen, we just go back to that leader who made that all happen so quickly and found a resource.
Of course.
Mr. Fat.
Yeah. He put that together. No, what an incredibly challenging set of circumstances and scene to try and navigate.
Yeah.
You can't even assess this patient. You can't talk to this patient. And the person you're communicating with is working off a value system so completely different than yours. Yeah. And at what point do you start to think, what is this situation?
Yeah.
We talked later. We said that there was a line in our minds that I would be willing to offend somebody if it meant saving this person's life. And it'd be different if we showed up there and there's an egregious impaled injury or a massive head wound that we could see. If at an extreme they still don't want us touched, I think we would have called police, had them removed, and gone to her as quickly as we could. But it was very challenging.
It was. We were able to, rule out the life-threatening things with using them as like our hands, basically. They were able to, there was no open fractures. The obvious injuries, I guess. She was awake and alert. So if those things were not happening when we arrived on scene, I think we would have had to handle that differently. It would have been tricky if she was unresponsive.
Yeah.
It's like...
And you don't know how the other providers on scene would have handled that either, right? If you're relaying to them, hey, I think this person is a critical patient, I need to gain access to them and transport them. Were the police going to breach that boundary, that religious preference boundary? Where's that line? The whole call was just one of the most challenging ones I can think of that occurred, and you guys handled it really, really well.
Yeah, because usually the people have their belief system, but when their loved one is like hurt and it is possibly life-threatening, usually they're willing to bend a little bit and let us do at least the bare minimum to rule out anything crazy. And I haven't had that again where they zero give in their belief system.
And they were, even to their credit, polite.
Yeah.
They weren't being forceful with us. They were just being very adamant, very stern that, no, we can't let you touch her. Mm-hmm. And I remember them being very grateful that we eventually got a female. It would almost have been easier if they were combative or difficult. Okay, well now you're impeding. But they were very polite, which made it almost harder. That there is still, they can respect my difference and my insistence. They'll refuse it, but
yeah. Especially like all the firefighters on scene just stopped talking to the patient or the patient's caregivers at all. Like, so they feel the judgment and they're handling it well. Why shouldn't we? And we did, but doesn't mean it wasn't tough. But
I've always used as a line for me, whether an activity or an event is dangerous or destructive. If it's dangerous or destructive, then I'm going to step in and exert control or whatever possible control I have over that situation to prevent it and stop it.
Sure.
But how do you can't even make that determination at this point because you see the damage to the vehicle. And it was a T-bone accident, right?
Correct.
Mm-hmm.
On that passenger rear door.
She was back, and that was a pretty significantly caved-in intrusion part of the vehicle.
Yeah. How much intrusion? Do you remember? Do you recall? Enough to be concerned.
By the time we got to this, she was able, I think they didn't jaws of life the vehicle. Maybe she was sitting on the opposite side, but it was several inches. It was crumpled
less than
in.
a foot, but
Window was broken
more
entirely.
Than 6 inches. Yeah, it was pretty critical. Definitely enough to spidey sense was going off.
Probably met trauma criteria for a trauma report just based on mechanism.
Mm-hmm. Like a Tier 2 or
Tier 2,
Tier
I believe,
2.
especially how fast the other vehicle was going.
Yeah. What Tier 2 criteria did the vehicle present at that you can recall?
I'd say the intrusion. We didn't know if she was wearing a seatbelt either. That was difficult to determine. So we did, for a minute there, we were concerned about her being unrestrained. The speed of the other car going through, it seemed to not hit the brakes at all. And we were at an intersection that enters from one and splits two ways otherwise. So he was probably going 35, 40 miles per hour.
Yeah, 0 skid marks.
Were you considering this a trauma activation or trauma alert? And if you were, what were the criteria you were looking at?
The initial on-scene assessment of the vehicles involved definitely had us concerned. The amount of intrusion did not make us comfortable. I think the longer we went without being able to fully assess her was making us more and more concerned to the point where...
Let me ask this.
Yeah.
By intrusion, because people listening to this may not understand. So by intrusion, what do you mean by that?
How much of the vehicle enters into the
patient compartment?
The patient compartment where she is sitting. So in this case, the vehicle struck the outside of this door and the door caved in into the space of where our patient was sitting. And if it's greater than 12 inches, then that meets one of two possible criteria to make a trauma alert.
Yes. And that one probably didn't meet it. It was less than a foot.
But there could have been other
the speed
elements there that you weren't able to assess that could have been. And what are some of those?
If the vehicle was traveling at more than 20 miles per hour, which almost, feels like every car accident.
Yeah, for sure.
If there was a death in the vehicle, which didn't apply to this. If there was an open long bone fracture, which we couldn't assess, she was fully clothed, or any possible severe hypotension,
Which you couldn't assess.
Correct.
Yeah.
Any possibility of being pregnant, which we weren't allowed to mention to anybody.
Couldn't even ask. Nope.
Off the table.
Not even them.
No.
Yeah. So, like, if her systolic was below 90 and she's pregnant, automatically a Tier 2, maybe Tier 1. It's a whole different thing when they're pregnant.
But even if it wasn't, like you say, we don't have a tape measure. The intrusion to where the patient is sitting, the speed of the vehicle, immediately made us want to extricate and I think a trauma alert would have been appropriate. Paint as close a picture over the phone.
You had a high index of suspicion
Yeah.
that this could have been a trauma alert.
For sure. Yeah.
I think I'd be willing to defend that too if people were asking, like, what is this? I'm like, well, listen, you weren't there. Pretty significant damage to the vehicle. Pretty significant mechanism.
What lessons did you pull out of this? This was probably, honestly, the 30 years I've been a paramedic, this is probably the most challenging situation that I've been involved with, just on the other end of the phone. It really is. And so what did we pull out of this? What are the lessons learned from this? Because you guys handle it like professionals, there's no doubt about it. And very frustrating situation as well.
I think patience and cooperation. You have to be willing to really go to places that you wouldn't initially. And if that means waiting longer for this patient to get the help that she will receive, okay. If it's not at the speed that I want it done, but it's going to be done in a way that we all get what we want, okay. I don't like just waiting, but we'll wait if it means that she gets to the ER.
Yeah.
If this situation was, say it was a car accident, there was no religious objections,
Sure.
but there was a male figure there preventing you from assessing this patient, where is the line where you would involve PD in separating that male overseer from the patient so that you could perform an assessment? You were pretty much there.
Without the religious element, it would have been so much easier. I would give him one or two, sir, I need to ask her this question. And then more firmly, sir, I can have you removed to ask her this question. This is imperative to her health. And if any sign of resistance there could, I think, validate me asking police to separate and let me really assess, especially if she seems fearful or like maybe she wants to talk to me. He's not letting her, then that's very easy. Let's separate them.
Yeah. Taking away the religious component makes that choice so much more black and white.
And I'm sure people listening to this may have a different opinion on that, whether or not they would have respected that religious objection.
Yeah.
And it was very fortunate, I think, in this circumstances that we were able to get another unit there with a double female crew.
Yeah.
And it was Shannon and Rika, wasn't it?
Shannon and Brooke.
Yep.
Shannon and Brooke.
Shannon and Brooke. I think if I ran into that same situation again, the only thing I would do differently is just come to the conclusion that we did a little quicker and try to get a female crew en route to our location pretty quick, and then see if we can convince this patient's caregivers that for us to be able to lay hands and assess our patient.
And the location of that wreck was kind of...
It was a little out of the way. Yeah.
It was on the outside of the county, right?
Yeah.
Outer edge.
Yeah.
It was a challenging place to get to in that period of time. To locate a crew, a double female crew, to get them there was also a challenge.
Exactly.
And it was busy at that point in time, so resources were scarce to make that all happen.
And yeah, that's the only thing we could improve on, I think, is just getting that female crew there to be able to for this patient.
Yeah, I think you summed it up pretty good, recognizing what you had and what you needed to correct it. But you guys handled it well. You really did.
We all did. Good team.
Yeah.
Go us.
That's
well
right.
handled.
We do have a fantastic team here. There's no doubt about that. Yeah. So how do you balance patient care with overall scene safety when conditions are unpredictable?
Oh, you have a good story about this.
I do. It's a situation I, looking back, could have handled a little differently. Our own safety definitely takes precedence. If we're not safe, we can't treat this patient. So if we need help and making sure we stay safe, then that's what we need to do. And definitely can't feel uneasy about asking. Like, you need to have a cop ride with you if you have a patient that has the potential to become violent. In this particular call, we did not. We had this, it's probably about 6'2", 6'4", 300 pounds, pretty massive patient. He was schizophrenic, lived with his parents, and he was just having an episode, an outburst, and parents didn't know how to deal with it. He started throwing things, getting a little violent, but didn't try to hurt them. He was just
Acting out?
Yes.
Yeah.
And so we were able to calm him down. I was able to talk with him, build a rapport. I felt like I connected with him enough to where I felt safe in the back with him. I felt like I knew the situation, and I felt confident being back there alone with this massive patient by myself. And most of the transport, that was true. He did start talking about some crazy stuff. He's best friends with Trump, and he started really going out there talking about politics, but then lizard people, and he started getting kind of crazy, and I was like, just listening. And then he starts touching me. He's like, oh, yeah, I put my hand here and we're good. And he put his hand on my knee, and then he put his hand in his lap. And then he was like, I put my hand here and we're fine. He goes a little higher up my leg on my thigh. I'm like, okay. I'm getting a little uncomfortable, but I can handle it. And then he just keeps doing that. And then all of a sudden he grabs my crotch, and he's like, and I put my hand here and we're good. And I was like, well, I grabbed his hand. I was like, actually, I'm sorry, my friend, we're not fine. Put it back in his, and I was like, let's not do that. And that's when I realized I did not make the right decision. I don't know what I'm going to do if this patient decides he wants to take me out. He
could overpower you pretty quickly.
Yeah. I got some ninja skills, but I don't think they will help me because he could just sit on me. And then he starts running his hands through my hair and laughing, and oh my gosh, that was peak
Matt,
terrifying
I
moment.
could think of 20 minutes ago I would have ended this call.
Yeah, that was awful. But he chilled out. I lucked out. I just played along with it. He didn't grab my crotch again. We got him to the hospital safely, and then we debriefed. And I let Christian know, like, ooh, let's not do that again. Next time, if we have a patient that has just the potential to be violent, we need to just prepare accordingly. So I always
And how do you signal your partner without screaming wildly? Hey,
yes,
this is not going in the direction we want it to go in.
Code names.
I think that's very big now that we have female partners. Because with you and I, there could be there's a little bit more of a safety net being there with another male. And so I think our code word at the time was Tom Brady. And it was almost even a joke. It just meant
because he's the greatest quarterback that's ever played the game.
Definitely not.
Because he's a cheater.
No,
and the
hey,
ball.
hey.
No, but we would use that almost as a joke. I'd kind of shout that through you, being like, hey, how did Tom Brady do last night? That was cueing you in, almost that I'm just a little uncomfortable. But that wasn't a hard stop to, you need to pull over. But now that with the female partner, I don't have the same world experiences as a woman. So I'm not even picking up on this partner maybe or this patient giving my partner uncomfortable eyes, or maybe he wants to talk to her a little bit more. And in most cases, that's fine. But sometimes they pick up before we do that this isn't right. He's treating me differently. And so we have to have much more subtle with them. And I think Michelle and Shelby had a great one where we need to go get the glucometer. It's something super easy to slip in. We get a blood sugar with the glucometer on every call. That's not something that requires both of them. But to almost 9 out of 10 people, they have no idea. That just lets them regroup, lets them kind of get out, and then they can debrief.
Yes, for sure. Yeah. Michelle is very animated with her facial expressions. I can definitely pick up on when she is uncomfortable, and sometimes it is something that I did not notice at all. And then I'm like, oh, okay, this is getting uncomfortable for her. I need to step in. So, knowing your partner and body language is so important. Yeah,
you should have a safe way to tell me, hey, for real, we need to step back, and I need you to tell you something that you're not picking up on.
I've always said to my wife, if we're out someplace and there's a situation developing that maybe we need to just get out of here, leave, I'll say typhoon.
Ooh, nice.
Typhoon, we're leaving. If I say that, get up.
Yeah. That's a nice, important little...
And we don't have typhoons on this side of the world, so if I'm saying typhoon, it's not because we're expecting one. It's we need to get out of here now. It's time to go. Yeah.
Emergency plans are important and definitely useful.
And you're in a similar situation to me, right? I have 3 girls and my wife, so it's going to come down. In a worst case scenario, I'm going to stay the last one out and deal with whatever's happening. Yeah. Typhoon. or it's in the garage. Check the garage.
That's
Right?
funny.
It's not an awkward thing to say in a conversation.
No.
It's
Slip
probably
in.
I left my bag in the garage or whatever. But if
Yeah.
that slipped into a conversation and garage isn't part of what we're talking about, then you know.
A good idea. Have a subtle phrase and a very obvious loud one like typhoon. That's a good
Typhoon.
idea.
Yep.
I'm running.
Yeah, it sounds silly to have code words but it's not, because when you need it, it works.
Well, and it's cool to have code words. That's not silly at all.
That's
Yeah.
fun.
Yeah.
Yeah.
Agreed.
And she can just look at you in the mirror with that man running his hands in your hair. I'm sorry. I say that. I shouldn't have lowered my voice.
That was pretty good.
Yeah.
No, that's good.
How you
This is
kept
all
your
right.
shit together, I don't know.
It is very. I was so scared that
God, I would have been too.
Yeah, it definitely made me realize too. Like, gosh, like I'm scared because this man is 6'4", 300 pounds, and could destroy me. And I'm like, gosh, is this how women feel most of the time, knowing that whatever patient can just overpower them? Because this is awful.
Yeah.
Definitely, yeah. That was an eye opener. I'm like, ooh, I definitely need to prioritize safety a little bit more. And I think I have. I haven't gotten hit yet.
There was a call that I reached out to you about early on where very large, probably 6'2", 190 pounds, one of the most muscularly built men I've ever seen in my life, was just frantic. And as soon as I get on scene, police tell me that he's all over the place. He just keeps talking, and he's not even remember what he's saying. I go up and I introduce myself, and he immediately he's shirtless, he's wearing Grady psych scrubs, puts both hands on my shoulder. You get that sense down your neck. It's terrifying. And he tells me he is king. And I just brush off his arms, real gentle, and he let me, which was wonderful, because in that moment, the police are right there, but he has me. At
Yeah.
the very least, he can just hold on to me. So that was rough. Tells me to call my father and tell my father he's going to beat me up and hurt me. But then he wouldn't remember.
I remember this.
And
As soon as you said that, I remember. Yeah. Continue, please.
I called you and like, okay, so I think this is appropriate to sedate. He's all over the place. He doesn't know where he is. He is so aggressive that he wants to hurt strangers. We need to sedate him. And I thought, this guy is just a rhinoceros. I don't think 300 of ketamine is enough. And so our doses would be, if I went purely off my suggested weight, would be close to 400. And I remember calling you, and I thought you gave me a good answer. He goes, well, you need to operate in your protocols, but more than so than that, you need to protect yourself. And so if this person requires more, then we'll have to figure that out together. But number one priority is making sure that you stay safe. And I felt very supported and protected by that. And luckily, 300 milligrams did it. I was with a lot of police officers that all really let me draw out the battle plan. We had a plan A, if he just lets me go up to him and get him. We had a plan B, if we had to hold him down. I had all of it drawn up and ready, and plan A went flawlessly.
Have you had the flu vaccine yet? Let me give you this.
It was a shot for an ant bite because his foot hurt. I'm like, oh, my friend, that'll swell. Let me give you something for that. Does it hurt?
There you go. That'll take care of it in about 10 minutes.
Yeah.
Gosh, dude was just a rhinoceros. It was so intimidating
Yeah.
and impressive.
And you make a very good point. Think about some of our female providers here, how vulnerable they can be made to feel.
I mean, I even think how much worse it is for female BLS units. They don't have the sedation drugs that we can rely on. And sometimes cities would code out psych calls as BLS, so they wouldn't even send fire or police. And here 2 female providers show up with a man who's capable of hurting both of them, and they don't have anything to defend themselves with. Very different.
I want to talk a little bit about partnerships. You guys worked so incredibly well together. The mutual respect you have for each other is incredible. The dynamics between the two of you are unbelievable. What are the red flags in a partnership? What are those red flags that, hey, maybe this isn't going to work out that well? Because you've worked with multiple people.
It's true.
I've worked with dozens of people over the years, and I've been very fortunate. I've always had really good partners, and maybe I'm more agreeable in that element of it. But what are the red flags that maybe this isn't going to work out, or the behaviors you see in a partner that indicate to you? What do you think?
There's like the real obvious personality differences. If we're working with someone that is not eager at all to be patient with difficult people or not willing to just kind of the same agreement of the standard of patient care. I hope that most of my partners, and here where I work, I'm grateful that almost all of them all agree that everyone should be treated with respect, that everyone deserves a fair chance, even if it's something silly. There's also personality difference of it's hard to be around someone that doesn't want to work, that wants to complain and argue with dispatch about getting calls, that wants to be disrespectful or difficult with hospital or fire staff. You're seen together. So when someone is not cooperating or is giving a disrespectful, rushing report to a nurse, it reflects on everybody. And that's
hostile towards other providers, maybe.
It's embarrassing.
And all those are opportunities to coach that individual on, hey, this is how professionals, this is not a professional thing to do, right? We don't talk to our dispatchers like that. We don't talk to nurses or physicians or firefighters or police officers like that. We have to work cooperatively together to accomplish what we're here to do, and that's to maintain safety, scene safety, safety of ourselves and other providers, but also to assess, treat, and if necessary, transport the patient. That's really what we're here to do. But sometimes that falls short.
Yeah. Sometimes, personalities do not mix, and there's just no way around it. I think being able to debrief after a call and talk about being able to complain about the call and some things that were frustrating, and then talk about maybe some things we could have done better. That's something Christian and I would always do after our calls. And that definitely has shaped us to be the providers we are. And when you don't have that with a partner, you can't even talk about what you could have done differently, what you did good. That if you can't have that space to be able to have that conversation, no one's going to grow in their career. And it's not helpful for the patient. And that's a big red flag for me. If I can't even talk about things that we could improve on with you because you don't want to deal with that, then it's going to be hard to have a partnership.
I'm as a leader, I'm fine if somebody comes in and challenges a decision I made or way I handled the situation. I'm fine with that. I should be able to articulate why I made a decision the way I made it, what my decision criteria were, and why I went in this direction. And I'm comfortable with that. And it doesn't happen very often, but it could. And it does every now and then, and I should be able to do that. And our differences are our strengths, I think, in some way. It's good that you see a situation, Matt, differently than I do. Because that may draw my attention to something I need to see. And I should be able to look at and reflect upon what you're saying and weigh it out. And see whether or not my decision-making criteria is valid or not.
Exactly.
I'm good with that. And if a call doesn't go well, and the reality of this business is sometimes calls don't go well. But if we can't sit down after the call and discuss what went well, what went wrong, if we're totally on two different pages whatsoever, and maybe it was a situation where the driving was excessive. Borderline unsafe. If the activity the person is engaging in is dangerous or destructive, that's the cutoff for me.
And you can't even have that conversation with them because they'll get offended and they won't change their behavior, and that's not helpful. And there's countless times Christian and I debriefed about a call, and I wasn't aware of something that he picked up on, and we talk about it after, and I'm a better medic after listening to Christian's thought process. I'm like, oh my gosh, I completely overlooked that. I'm so glad we had this conversation. I got to keep that in the forefront of my mind next time.
That makes you better, right? Iron sharpens iron.
Yeah, that debrief is super important. And it's so apparent when it's not a space you can do that with someone. And one of the days I didn't work with you, I had a difficult call where an otherwise healthy man had a sudden hemorrhagic stroke. And while my paramedic did the patient justice through his assessment and treatment, it was just callous and cold. And within 10 minutes of our transport, this patient had deceased. And that happens, but that upset me. I wanted to talk about how, isn't this wild that a man just is gone now? And he was healthy this morning, and his family was there, and we were the last ones to speak with him, and my paramedic was just completely unfazed. Didn't want to engage in that with me at all. It was uninterested and just was ready to go home. And that was disappointing. That was just, I don't want to work with this person anymore.
Yeah.
There's just a lack of sympathy and not even...
Are they compartmentalizing, putting up a wall to protect themselves from the reality of what just happened? Is that a possibility?
Maybe with this individual, maybe that's when it started, and this person just got too comfortable with not having that. He's no longer here.
Detaching from it. Yeah.
It's difficult to be around with other patients. It's one of those people that was constantly arguing with nurses. Just not a very people person, and a very people person required role.
Yes.
Yeah. Soft skills, right?
Soft skills.
Yeah. Yeah, that's another, all those things are so important in a partner. Like, you are in a confined space for 12 hours at a time, sometimes working 3 days in a row. So in 3 days, you're with the same person for 36 hours, just you and them. If your personalities are not mixing, like, that alone is enough. You can tolerate people, but is you just tolerating your partner gonna affect the patient care? And once it reaches that point, that's when you need to talk to your supervisor, let him know, like, I'm not providing the best patient care because I'm not comfortable with my partner, and we're just not agreeing. And luckily, Christian and I we lucked out. We didn't even know each other that very, very well at all. I barely knew you, and you wanted to just work full time with me. And I said, sure, and
I was charmed by the eyes.
Yeah, my green eyes, his blue eyes. Goodness, we were locked in.
I'm feeling uncomfortable.
Good. Yeah, we have that effect on.
Trust, I think, is one of the biggest things.
I agree.
Right? In a partnership, you've got to be able to trust the other individual. Because if something doesn't go well, you need to be able to discuss it and determine what were the elements of that call that didn't go well and how could we have done it better without it turning into, where does the trust get breached? How does that trust become breached? What does the person do beyond that call that can breach the trust? Let's talk about that. Or not, if you don't want to.
It's easier to start from where trust is earned.
Yeah.
So when you come to work, and let's say we call it flavor of the day. If you don't have a full-time partner, you work with anyone that really they just put you together with. And there's a base almost understood, hopefully, at the very end of the day, I'll at least take care of my partner, and I understand my partner will take care of me. In a professional sense, when you have someone that you get along with so well and you start to develop personal relationships, you start to maybe hear about their personal life. I was blessed to have gone to several of Matthew's children's birthdays, and Matthew came to my graduation ceremony. So it gets that trust built very, very strongly. And you don't have to do that with every partner. You can keep things professional. But it's so when that's lost is when you just don't feel that equal respect anymore. The trust is lost when there's just a disregard to your professional opinion as well as just personal respect. If I wanted to talk to Matthew either on or off scene, say, hey, I wish we had done something differently, he doesn't even have to agree with me, but I would at least hope he'd hear me out. The trust would be lost if he would tell me that you're the EMT, just drive. Well, there he's lost my trust that I could share with him that we could be doing better.
Yeah, trust is key.
It's interesting. People will come to me every so often with a partnership issue and tell me a story of something that happened. And is this just for me, I try to evaluate, is this just a difference of opinion on how they provided care or how they approached a scene? Is this truly a safety issue?
Sure.
Or is this a personality conflict that's occurring? And I usually dive into a little, did you discuss it with them? Did you talk about how this happened or unfolded or what could have been better or different? And oftentimes that answer is no. No, I didn't. I didn't think they were going to hear me out.
Sure.
Well, I happen to know Matt fairly well. I think I do. That whole fingers through your hair thing threw me off. I'm going to be honest with you. I know it affected you too.
Oh my gosh, yes.
But you know what? I know both of you are extremely reasonable people. And if somebody said, hey, this made me uncomfortable, or I don't like the way you spoke to that patient, or I think that you would be very open to hearing that and you would take it very seriously. I think it's okay to come to me. It's okay to go to a leader and say, hey, I'm not comfortable with this situation. But if you choose to do that, you could be breaching that trust and damaging that partnership. But if they're engaging in an activity, and I'll say it again, dangerous or destructive, then you almost have an obligation to do that.
Yeah.
And I'm going to hear that out and I'm going to take action upon it, because we're not going to put our partners, our coworkers, our patients, our partner agencies in any type of danger. We're just not going to do that. We're not going to allow activity to go on that crosses that threshold.
Yeah. And that specifically hits back home with now having female partners. So I owe my partner, who's a good person, a good friend, and a good coworker, the space to tell me that something's uncomfortable. And I ask her every time, if a family member requests to ride in the ambulance and they're going to be riding shotgun next to my partner, I prompt her, like, well, let me make sure that this patient's stable and I'll be right back with you. And I'll ask Shelby, do you feel comfortable with this person riding in the ambulance? And every time she said yes, and I know she feels comfortable telling me, no, there's something about him, or no, she's a little too upset about what's going on. I don't feel, and I every time will listen to that, because I'm not the one that she's going to be sitting next to. It'll be my partner.
Good. Think about it. You're in the back of that ambulance. If that ambulance is moving, there's no way for you to get up front there and stop something.
And I've been focused so much on patient care that maybe she's seen a little bit more of a family dynamic, or maybe she's been more observant. And so I trust her instincts very much if she's not comfortable with that. And the same goes with patient care. If we've got a psych patient that even if I'm riding their back with, I'll always ask, are you cool with just the two of us? Because if I get attacked, it's going to be up to her to do something. And if she doesn't feel like that's something that she can do alone, she will, let's reconsider. Mm-hmm. It was just the two of us, and we had the stair chair patient. We're both of smaller stature. Shelby, I think we can do this, but do you feel comfortable doing this, the two of us, or would you like fire there? So I think that is key. And doing that from the jump has already made the two of us so much more efficient as patient care providers.
It builds on trust.
It does.
I agree.
Me too. Excellent point.
Oh, thank you. Thank you very much.
What role does humor or camaraderie play in maintaining resilience in a shift?
Oh, it's a blessing to have a partner that you can share that with. We would, our go-to for a long time, Matthew and I, would be to throw the football. If we had a period at post, and just doing so would bring out so fluently conversations that we didn't think we'd have. I'd be throwing the football, and I'd tell them that, hey, I didn't tell you this, but my mom and my dad are moving or about to retire, and that's exciting. Or just the little subtleties of being able to share and joke around and find something similar just really strengthens a partnership. It makes things so much easier.
Yes, definitely need that. I do. And I've been fortunate enough, me and Christian and our sense of humor matched, and we were able to deal with a lot of trauma and a lot of terrible people at their worst. And the gore is hard to process sometimes. Sometimes just the scene is so, people do terrible things, and we're supposed to process it in 30 seconds. And me and Christian would deal with a lot of, all of what we saw, make jokes about it, try to make light of it, but also bringing it up and talking about it in a comfortable way is so important. And we were pretty good about that. And Michelle, I've lucked out. She's very funny and also has a good sense of humor. And,
She does.
And her and I are able to do the same thing and kind of debrief, make sure we're okay. We're not, that sense of humor is very important, at least for me, and just dealing with the scenarios we're forced into every day at work. I don't think I'd be able to cope if I wasn't able to joke around about the things that we've seen. And it has to go a little bit beyond that, but the humor opens the door for that conversation to have. So you may make a joke, talk about what you just went through, and maybe a little bit of a serious conversation will come out of it, and you guys can process things together. That's so important. Like if you don't have that, you go to your personal life and you can debrief that way as well, and figure out how to deal with these new images in your head or terrible scenarios that you find like running through your head. You need to have a good system to lean on outside of work, but in work as well. Like the immediate dealing with some crazy scenario, it's very important to, humor is definitely a deal breaker for me. Thank God Michelle's funny.
In our job too, I bet if random people could hear what the jokes we're making, it would come with a lot of judgment. It would come off as that we are just very unserious, uncaring people. And
it's not, though.
It's not. It's just a way of coping. I could look to Matthew and make a comment about a patient that might have been covered in fecal matter, and he knows that I can talk to him about that as a way of processing, way to deal with this without humiliating her. It's nothing I would ever say to her, or it's nothing I would say to someone that would make them think I don't view this as a person. But then privately I can go, dude, that was everywhere. I can't believe we just had to deal with that.
Yeah.
And it's not coming from a disrespectful place, but from outside terms, it would come with a lot of judgment, and that's the security and the trust built upon with your partner that the humor really comes key with.
For sure. Yeah.
I agree. When you have a really good relationship with your partner, you will know if Christian isn't handling something well. You can talk about to deal in your situation there. I don't know, what do they call it when you wrap the patient? A burrito? A poop burrito? What is it?
I don't know.
Poop burrito. I don't know the slang term for it.
It's you wrap them up.
Matthew was never careful with that when I had to clean the stretcher, so he didn't really care how nasty it got. It wasn't his problem.
Not true. I'm a team player, and I help you.
I never heard of a poop burrito. That sounds so much cleaner and easier to deal with.
That does.
When they're covered in it, you kind of wrap them up neatly like a burrito so that you kind of contain all that nastiness, right?
Yeah.
But you'll know if there's something wrong.
Yeah.
He's not processing or handling, and vice versa.
Of course.
That's really a good thing. That dynamic is good because you can alert or direct help when it's needed.
Yeah, and you can know when you know them enough they need space for a minute to process what's going on, or maybe they just need someone to interject and just bring up the incident so they can, because they won't talk about it on their own, but that's what they need. And sometimes that is the opposite of what they need. So, yeah, building that relationship with your partner you don't have to have that. You can just have a full-time partner that you don't have anything in common, and you can get by and still do your job. But are you going to provide the best patient care possible? No, because it is a partnership. There's an EMT and a medic on every call, and both play very important roles. And if you don't have any sort of relationship built up, it's just hard to just provide the best patient care possible.
The best part of my day, there are some really great, when I see you guys out at the hospital, I get to interact with you and see the patients you're with and what you're doing. The busiest part of my day is right around shift change. We're taking trucks down, we're putting trucks up. The crews are coming in. It's the busiest. It's also the best part of my day, and sometimes it's also a little bit frustrating because you guys are coming in. You're telling me about your day. You're telling me about those calls, some funny ones, some stressful ones, some really bad things that have happened, and I love hearing those. I love that when the crews come in, they tell me a challenging call they had that day. I just love hearing the stories. And it can be frustrating for me. Yeah. I got somebody calling who wants to pick up a shift, and I got to put that in, and it takes me away from being able to be in the moment.
That's tricky.
Yeah, but I love that happens. I think I feel connected.
People feel comfortable enough to share their trauma with you, and that's another way that they're coping with it, and you're playing a positive role in that. That's pretty awesome.
Yeah. I really like that part of the day, and it connects me to you guys, to the crews. It connects me to EMS, and helps me work through some of the stuff I've seen and been through over the years. It's all good stuff. And you guys are just fantastic individuals. You're excellent paramedics. I know you're just beginning your career, Christian. You're in the early stages of your EMS journey, but
a little embryo.
Man, you've done so well.
Thank you.
You're right on track. You got it. You're in the slipstream, right? Is that what it is in NASCAR? Yeah.
I think so.
And you had somebody really excellent to work with over the years. Matt, you're just a fantastic guy. Good, great paramedic. No doubt about that. I'm so proud that I get to work with the group of people I work with every day, because every one of you is smart and good at what you do. And I've seen thousands of paramedics over the years come and go in the different roles I've had and the different areas I've worked in. And this is really a talented group of people we have here. And there are definitely some challenging people.
Of course.
But they ultimately test me and make me better at what I do. And I just thank you guys for being here. I'm glad you came in tonight. You stayed after a long day to do this. But I think the things we've discussed are valuable. And thank you.
Thank you.
Yeah, thank you for the opportunity. It's been awesome.
Yeah, great.
Thank you for listening to In-Service, the EMS Podcast, where frontline experience meets leadership insight. If you have found value in this conversation, please like, subscribe, share, and leave a comment. You will find links in the episode notes.